My name is Liana Abrumele. Well, sorry. It's the very first time that I share my screen, so just went just a sec. Yeah. So, welcome everyone. I'm Liana Abrumele, bone marrow transplant nurse in Hadassah and Karim Hospital since 2018. And today I'm excited to share some evidence-based strategies in the care of immunocompromised patients with you that I think that might make a real difference in patients' outcomes. How many of you have cared for a patient who developed a life-threatening infection that could have been prevented? Today, we'll explore how to minimize these risks and while maintaining their quality of life. Those will be our learning objectives. These aren't just theoretical concepts. Everything we discuss today has direct bedside application. We'll cover a lot of ground in the next 25 to 30 minutes, moving from foundational concepts to advanced practice consideration. Our learning objectives will be about defining immunocompromised states, implementation of evidence-based infection prevention strategies, demonstration of appropriate isolation precautions and environmental controls, application of safe medication administration, recognize signs and complications recognizing early signs of complication and implement timely intervention and patient education. Now, let's begin by ensuring we all have the same understanding of what makes a patient immunocompromised. The term immunocompromised gets used frequently, but let's be precise about what we mean. Immunocompromised patients have weakened or impaired immune system that cannot effectively fight infections, malignancies, or other diseases. Primary immunodeficiencies are rare genetic conditions, but secondary immunodeficiencies are what we see on a daily basis in our wards, either oncology, hematology, or bone marrow transplant. Most of our patients become immunocompromised because of the treatments we give them. This creates both opportunity and responsibility. Think of immunity as a coordinated defense system. When any component fails, the entire system becomes vulnerable. Now, for an example, a patient receiving high-dose chemotherapy may have intact antibody production, but not functioning neutrophils to fight bacterial infections. Another example is post-transplant patient may have adequate cell counts, but immature, so they're non-functional immune cells. Now, let's identify which patients are at the highest risk in our daily practice. So, who are our immunocompromised patients? We have three sections over here: the bone marrow stem cell transplants, either auto or allo, or also there's the CAR T cell that we do as well in our department. There's also the hematological malignancies, patients that have hematological malignancies, such as acute and chronic leukemias, lymphomas, multiple myeloma, so on and so forth, and other high-risk conditions such as AIDS, malnutrition states, and inborn error immunodeficiencies. So not all immunocompromised patients carry the same risk level. When you look around in your hospital units, there's a variation of these patients that you see on a daily basis. Allogeneic transplant patients face the triple effect, which is the conditioning regime toxicity, graft versus host disease, and also the immunosuppressive medications that we give them. Now, hematological malignancies, patients who have hematological malignancies, these patients often have disease-related immunosuppression before we even start their treatment. Leukemias are particularly high risk because they directly affect the immune cell production. Now, don't forget about the solid organ transplant patients who might be admitted to one of your departments. They are chronically immunocompromised. Now remember that immunosuppression, it's not binary, it's a spectrum. A patient with mild neutropenia receiving outpatient chemotherapy has very different needs than a +10 post-transplant patient with profound neutropenia and mucositis. Understanding the risk levels lead us to our assessment framework. Now, the risk assessment framework over here, there's the neutropenia classification, which is mild, moderate, severe, and profound, with the absolute neutrophilic count either from 1,500 to 1,000 or 1,500, below 500, and below 100. This isn't just about memorizing numbers. It's about clinical decision-making. These classifications come from decades of research correlating infection risk with specific parameters. A patient with ANC of 300 for 2 days has very different risk than someone with the same count expected for 3 weeks. Never rely on ANC alone. Consider the whole clinical picture. For an example, a 70-year-old patient with diabetes, central line, severe mucositis may be higher risk at absolute neutrophil counts of 800 than a healthy 25-year-old with an ANC of 400. Post-transplant patients often have additional risk factors like GVHD, steroid use, and previous infections. Another example, a 45-year-old patient with diabetes, possible underlying TB exposure with absolute neutrophil count of 300 and mucositis may be at higher risk than the textbook suggests. Now, in your assessment, always ask, what's the nadir expected to be? How long will it last? And what other factors might increase the risk? Once we understand the risk, we can implement appropriate prevention strategies. Now, the infection prevention. We all know the hand hygiene, the 5 moments. That's before touching the patient, before a procedure, just as we see in the picture. And the minimum hand rub is supposed to be 20 seconds. We're going to talk about sophisticated intervention over here, but nothing replaces basic infection prevention. Hand hygiene alone can reduce healthcare-associated infection by 30 to 50%. I cannot overstate this. Hand hygiene is our most powerful intervention. The WHO 5 moments give us a framework, but with immunocompromised patients, we should think about hand hygiene before, during, and even after every patient interaction. Unless our hands are visibly soiled and dirty, alcohol-based hand rub is more effective than soap and water, and it causes less skin damage with frequent use. I often see staff focus on complex interventions while missing basic hand hygiene opportunities. Remember that gloves do not replace the hand hygiene, they supplement it. Building on these basics, let's discuss environmental controls and isolation precautions. Now, the isolation precautions over here, environmental controls are important, but we must balance infection prevention with maintaining human dignity and quality of life. Not every immunocompromised patient needs a protective environment. Let's use evidence to guide our decisions. These are specific evidence-based criteria. We don't put someone in PE just because they have cancer or low neutrophilic counts. HEPA filters remove 99.97% of particles 0.3 micrometers or larger. These includes most fungal spores and bacteria. Positive pressure prevents contaminated air from flowing into the room when doors are open. When PE rooms aren't available, we need to prioritize our patients with highest risk, such as allogeneic transplant patients with profound neutropenia with more than 7 days. Base your restrictions on evidence, not fear. A healthy family member poses minimal risk with proper precautions. PE rooms are expensive and can feel isolating. We use them when evidence shows clear benefit, not as a default for all immunocompromised patients. Over here, you could see that the standard room modification, the daily disinfection with EPA-approved agents, the removal of potential reservoirs of plants, flowers, tap water for consumption, and limit the visitor access and screening. Just as I previously said, don't limit the visitors, the family who are healthy, because we need the proper precautions. Now, environmental controls work with appropriate personal protective equipment, which is the PPE. PPE is only effective when used correctly and consistently. Match your PPE to the actual risk, not the perceived risk. Clean gloves for patient contact. Mask when you or the patient has respiratory symptoms. This covers most of the situation. Reserve the N95 for suspected airborne infection or during aerosol-generating procedure. Standard surgical masks are adequate for routine care. Gowns aren't routinely needed unless there is a risk of extensive contact with patients, secretion, or contaminated surfaces. Donning sequence, which is the hand hygiene, then we put on the gown, mask, goggles, another time hand hygiene, and then gloves. The doffing is the reverse, with hand hygiene between each and every step. The most common error I see when doffing is touching the outside gloves during removal. Help patients and families understand why you're wearing the PPE. It's to protect them, not because they're dirty or contagious. Now let's discuss medication consideration for our immunocompromised patients. Medication errors in immunocompromised patients can be catastrophic. We're often giving medication to prevent problems before they occur. We give prophylactic antimicrobials because these patients can't mount effective immune response to fight infections. And the live vaccine contraindication, this is absolute during the active immunosuppression. Even household contacts should avoid live vaccines when possible. Drug interactions. Immunocompromised patients often take multiple medications. Always check for interactions, especially with antifungals. Start with antifungal prophylaxis before counts drop, not after the patient develops fever. Voriconazole requires therapeutic drug monitoring. Levels that are too low are ineffective, too high causes toxicity. Use enhanced sterile technique for IV medication, especially with central lines. Some medications required filtered needles to remove particulars that could cause emboli in patients with compromised circulation. Medication safety leads us directly to nutritional support and food safety. Now, good nutrition supports immune recovery, but we must balance nutritional needs with infection risk. Food restrictions have evolved. We're less restrictive now based on evidence. Focus on foods with highest contamination risk, like raw eggs, unpasteurized dairy, and undercooked meats. The internal temperature of the meat is supposed to be 165 Fahrenheit, which is around 78 Celsius, if I'm not mistaken, thoroughly washed fruits and vegetables, and to avoid buffet food. Traditional neutropenic diets removed all fresh fruits and vegetables. However, current evidence shows thorough washing is usually sufficient. Use validated nutrition screening tools. Not just does the patient look thin, such as albumin, prealbumin, and transferrin, give us objective measures, but remember, they can be affected by inflammations. Offer nutritional supplements between meals, not with the meals, where they might reduce the food intake. Parenteral nutrition, which is TPN, increases infection risk through central lines. Use only when enteral nutrition isn't possible. Good nutrition supports recovery, but we must also recognize when complications are developing. This is the early recognition complication. I divided it into 3 sections: the infection warning, the hematological complications, and other critical complications. In immunocompromised patients, early recognition can mean the difference between life and death. These patients often have blunted inflammatory responses. Symptoms may be subtle. Single temperature above 38.3 or 38 Celsius, sustained for 1 hour. Do not wait for significant fever. Immunocompromised patients may have serious infections without fever, elevated white count, or classic symptoms. Consider infection in any system: respiratory, GI, CNS, skin, and bloodstream. New cough, shortness of breath, or chest pain could represent pneumonia even with clear chest X-ray. Subtle mental status changes might be the only signs of CNS infection. New rashes could represent disseminated fungal or viral infection. Look at patterns over time, not just single values. A rising lactate or falling blood pressure might be more significant than absolute values. Know your patient's baseline as well. Some patients always run low-grade temperatures. When in doubt, obtain cultures and notify the physician. It's better to overreact than miss a life-threatening infection. Another complications are the hematological complications such as bleeding, petechia, bruising, signs of anemia, fatigue, dyspnea, thrombotic events, the swelling, pain. Other critical complications such as TLS, tumor lysis syndrome, or graft versus host disease manifestation, and severe mucositis or skin breakage. Early recognition depends on appropriate laboratory monitoring. Now, laboratory values guide our interventions, but they must be interpreted in clinical context. Individual values matter less than trends over time. Daily CBCs during high-risk periods help us anticipate problems and adjust care. Obtain cultures before starting empiric antibiotics when possible, but do not delay treatment for cultures. Prolactin and CRP can help distinguish bacterial from viral infections, but clinical judgment remains primary. Galactomannan can detect invasive fungal infection before clinical symptoms appear. Regular CMV monitoring in transplant patients allows primitive treatment before disease develops. Monitor lymphocyte subsets to assess immunorecovery post-transplant. Just context, a little bit of an example. A CRP of 50 might be normal for a post-operative patient, but might be super concerning for someone on chemotherapy. Some tests take days to become positive. Do not rule out infection based on one single negative result. Laboratory monitoring supports our clinical care, but we must also educate our patients and families. Me personally, patient education, if you take anything out of this presentation today, take the patient education with you back home, because it can either break or make a breakthrough for you. So patients and family are our partners in preventing any complication. Knowledge, it reduces anxiety and improves compliance. Focus on practical, actionable steps. Patient can take hand hygiene, recognizing the simple symptoms, when to call for help. Help patients understand why each medication is important. Compliance improves when patients understand the why. Be realistic about restrictions. Complete isolation isn't evidence-based and harms quality of life. Use written materials, demonstrations, return demonstrations, and verbal instructions. Have patients or families explain back what you've taught to ensure they've understood. Adapt teaching to cultural beliefs and practices. Common challenges. Prioritize the most critical information first. You cannot teach everything in one session. Address fears and misconception. Some patients become overly restrictive from fear. Include key family members when it's appropriate in education. They often provide much of the home care. Make sure patients know exactly when and how to contact the healthcare team. Provide written emergency contact. Patient education connects to our broader psychosocial support efforts. We treat the person, not just the immune system. Survival isn't meaningful if patients cannot enjoy their life. Anxiety, depression, and social isolation are nearly universal in our population, in this population that we treat. Regular psychosocial assessment should be part of our routine care, not an afterthought. Remember that immunocompromised illnesses affect entire families and not just our patients. Do not hesitate to involve social workers, psychologists, or even psychiatrists. Connect patients with other patients who've had similar experiences when it's appropriate, and help patients continue meaningful activities within safety guidelines. Sometimes the psychological benefit of an activity outweighs small infection risks. Involve patients in decision about their care restrictions and consider how current restrictions will affect long-term psychological well-being. Comprehensive psychosocial care requires effective team collaboration. Caring for immunocompromised patients requires expertise from multiple disciplines. Good communication is the foundation of effective teamwork. Everyone should understand their role and the roles of other team members. Daily rounds, structures handoffs, and regular team meetings prevent important information from being lost. Complex cases benefit from multiple perspectives and expertise. SBAR format, Situation Background Assessment Recommendation, provides structure for important communication. Now, for care plans, keep care plans current and accessible to all team members. Regular family meetings prevent miscommunication and it aligns goals. Comprehensive handoffs are critical. They are super critical during the transition from ICU to floor or floor to ICU, shift to shift, hospital to home. Start discharge planning on admission. Complex patients need extensive coordination. Effective teamwork supports our quality and improvement efforts. This is our final slide, and it provides the resources for continued learning and improvement. Remember that caring for immunocompromised patients is both a science and an art. Use evidence-based to guide your practice, but never forget that human beings are at the center of our care. Thank you very much for listening.
Thank you very much, Liana. That was very insightful, and I think it's a very important subject for us to look at. As Cyril said with our previous training session, that in South Africa, a lot of the units, whether it's in the hospital or private setting, we nurse oncology, which is solid tumor patients, as well as hematology patients. And a lot of these principles can be taken, moved from the hematology to the oncology. Obviously, our oncology patients won't experience such severe cases of, neutropenia and things like that, but it is very important, like you said. And the other point that I just wanted to reiterate and go back to is that we need to assess the patient as a whole, because like you say, if you've got a low count, it doesn't necessarily mean that it is the patient's immunocompromised. It's the AML patient, or it's maybe treatment related, but the patient's not necessarily at risk of having complications as such. So what we do at our practice, if a patient comes in and we know what is the background and the treatment that the patient has received, we do the blood tests, and we like to look at the CRP count, because you will have a patient on AML with a hypermethylating agent day 5 post chemo, and you'll come in with a white cell count of 1.5, and everybody's like scared. But then we obviously look at the CRP and we see, okay, it's normal, you know, the patient's apyrexia, all of those things. And then just to jump over to the hand hygiene, that's absolutely so important for all of our departments. It is our first, I would say, our first line of defense to prevent infection within the departments and the hospital. So we can't put too much emphasis on that. And then, interestingly enough, when I started working in the hematology department, you know, with the dietitians and talking about the neutropenic diet, is absolutely interesting. And I think that would be something nice to share with the rest of the country as well, the actual neutropenic diet. And it was interesting for me to hear that there have been advances, you know, that the limitations aren't that severe anymore, or that heavy anymore. And that's very good, because like you said, from a psychosocial perspective and for patient autonomy, you want them to continue life as normal as possible and not limit them, you know, with like a basic thing. So they are still able to be able to follow, to sort of have quite a diverse diet still, and not be limited to you know, all of these very, very heavy limitations. And just the last point that I would like to just chat to you a little bit about, because I know you're very, very passionate about it, and it's your patient education and involving the family members as well. It's such a critical point, because the caregivers, the patient, you know, they're not feeling well. They're overwhelmed with all of this information. So it is important to have the closest caregiver and have the patient education session with them, and be able to get them on board and chat to them, and you know, and make them aware of the signs and symptoms, what they need to look out for. And with that, I would like to, if there's anything else from your side, or I would like to open the floor for questions.
I'm open for questions right now if anyone would like to ask anything.
If there's any questions, you're welcome to unmute your mic and you guys can chat with us. Please do. Or if you would like to share any experiences within your departments, or anything interesting that's happened that you would like to share with us, and we can share good best practice, that'll be awesome. Thank you so much.
Yes, Sarah.
Hello, Liana. Thank you very much for an insightful presentation. And yes, there's quite a lot of common things, obviously, in terms of how we care for our patients. But I'd be very interested to know, there in Jerusalem, Israel, that in terms of your management of a neutropenic patient or a stem cell transplant, for instance, allogeneic stem cell transplant, you as nurses, do you take extra precautions like using your usage of scrubs, gowning, and all that, or just to use normal uniform and do not going an extra mile? Are you in that place as well, or how are you doing it?
So in my department, actually my department is 2 sections. There's a section for adults and a section for pediatrics. And in the whole department, we have the HEPA filters. And whenever we go into any room, we only use the hand hygiene, the Hadisol, which is the alcohol hand scrub, unless there's a need for an extra prevention strategy. When Corona hit, we used to go inside each and every room with surgical mask. We just recently took this out and we went back to going inside of the rooms maskless. But other than that, it's hand hygiene and the same hand hygiene techniques that I've talked about, the WHO 5 moments and the, I guess also in your departments with the CDT and the contact isolation, then there's specific precautions to be applied within the PPE. But other than that, we go by the basic. Is there any other question?
I just want to know from Leonard, was a very, very good presentation. And I just wanted to confirm if we will be posting it somewhere so we can refer back to it. Cyril, I can't remember, sorry, what was the arrangement last time, what we said, that if we will be able to have the presentations available somewhere.
Hi, Trina, it's Dr. Parisnath.
Hi,
I think,
Doctor.
I think perhaps on the blood assay, are we not posting them on blood assay? We just need to double check.
Perfect. Thank you very much. Yeah,
thanks.
I understood that. Thank you so much.
Thank you.
Guys, and if there's any other question, anything from the floor, any comments, I would like to close this session, and I would like to say thank you very much to Liana for your time. And it was a great pleasure to have you here with us, and thank you so much for your support. And the EBMT Nurses Party, with your support, getting us up and running. We really appreciate you. Thank you so much. Have a lovely evening, everybody.
You too. Have a lovely evening, everyone. Bye-bye.
Bye-bye, guys.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye-bye.